Thank you for joining me. My name is Janine Evasick, and the purpose of this video is to let the general public become more aware of the huge problem that exists in cancer care right now, with advanced cancer patients not receiving the prognostic information they need to make informed decisions, or sometimes not adequately understanding that information, even if they do receive it. There's much evidence in research that lack of prognostic knowledge results in so much needless extra stress and suffering. And this is presently a hot topic in cancer care right now and in cancer research, particularly with more and more people surviving even advanced cancer, but then needing supportive care for an unknown number of years. And without prognostic understanding of what is happening to their bodies, we're seeing terrible outcomes for both survivors and their families. What often compounds the problem is that as years pass, many survivors are no longer receiving oncological care. And so their health needs are being addressed by doctors who aren't familiar with the long-term effects of treatment. So improving prognostic communication oncology was the topic of my MS thesis in health psychology several months ago, and continues to be my focus as I go into a PhD program. The reason why I'm so interested in this work is because of my and my late husband's experience. He was diagnosed at the age of 30 with a rare testicular cancer, had reached stage 4, so widespread throughout his body. After about 7 months of treatment, the cancer was eventually halted by experimental high-dose chemotherapy in 2004, considered experimental anyway. And this was followed by stem cell transplant. However, he was prematurely aged by the effects of treatment and lived with continuous health issues for another 12 years and died unexpectedly at home. What had happened to his body was never explained to us. Instead, he kept struggling to live as if he was a normal 30-something and with a potentially normal length of life ahead. Family and society also expected him to continue his life as if he hadn't been changed. Simply knowing his prognosis, even without any other clinical support, would have made a huge difference in our final years together. I would have known how to be a better advocate for him, particularly with medical care, and we would have been able to make at least some of the difficult existential adjustments that we really needed to make in order to make the most of our remaining years together. And we both would have had more understanding and support. Most importantly, he would have lived with greater dignity. With prognostic understanding, specifically that treatment had only prolonged his life for a while, we would not have needed to isolate ourselves from those who didn't understand and struggle so much on our own. So this is something to remember when we hear that more and more people are surviving cancer. The number of deaths from cancer that are recorded are not reflecting survivors who lived longer but still died prematurely because of having cancer. They may not have died directly from their cancer. The cause of the death for my husband, for example, was recorded as organ failure at the age of 43, which was, of course, from the effects of treatment. So statistically, it appears that there was one more person that survived this rare cancer called seminoma and also survived stage 4. So now let's look a little closer at what the problem is and what can be done about it. Okay, so let's define the word. Prognosis is about so much more than life expectancy. Prognostic conversations with physicians ideally include the different treatment options that are available and the pros and cons of each, symptoms that can be expected from the cancer continuing to spread, but also symptoms that are likely with the various treatment options and how undesirable side effects can be dealt with. Ideally, in modern cancer care, an emphasis on improving the day-to-day quality of life for both patients and their families is part of having a good prognostic conversation with your doctor. And this focus on managing symptoms on a day-to-day basis has been shown to be vital to engage patients and caregivers in productive prognostic conversations, and of course is essential information for them to be able to make the medical decisions they need to make and about what treatment options to pursue, as well as see choices in their personal life for them and their family to live as well as possible. So, looking at some statistics, it's estimated that only about half of the patients with advanced cancer are aware of their prognosis, even as they near the end of life. This percentage is fairly consistent throughout the world and has been shown to be even higher depending on the cancer. For example, in a survey of 10,000 people throughout the US who had incurable cancers, a large percentage had beliefs of curability. 81% of patients with metastatic colon cancer, for example, had a belief they could be cured. Inequities accessing quality cancer care are also reflected in rates of inaccurate prognostic understanding. For example, elderly patients with reduced cognitive function and lower education may have difficulty obtaining and using prognostic information. And Latino patients show the highest rates across all groups of people of inaccurate prognostic understanding at 82%, including 65% having no knowledge of their cancer stage. The American Society of Clinical Oncology has reported that realistic conversations about treatment options appear to occur in less than 40% of patients with advanced cancer. For patients and family, prognostic understanding is strongly associated with a patient's care goals being met. Better prognostic understanding also correlates with drastically higher quality of life scores for both patients and informal caregivers. Lower caregiver burden is also associated with prognostic understanding, including into bereavement for the caregiver following their loved one's death. Less hospitalizations and potentially prolonged survival for the patient has also been shown with greater prognostic understanding. Poor prognostic understanding, on the other hand, is strongly associated with higher rates of depression and anxiety in patients and caregivers, and increased use of non-beneficial, aggressive, and costly end-of-life treatments. So research does show that most adult cancer patients and parents of children with cancer want all available prognostic knowledge. Greater trust, hope, and satisfaction with medical care is reported by patients and family when they receive honest prognostic disclosure. A noteworthy finding from one study was how the ability to gain prognostic knowledge gave patients and family a sense of control over their lives. Learning more about the disease and treatment options, simply understanding what was happening with the body enabled them to cope better and allowed patients to focus on personally meaningful goals that were attainable. So more compelling statistics showing that clinicians also suffer the consequences of their patients not accurately understanding prognostic information. It's estimated that 45% of oncologists in the US are experiencing burnout, with greater than 85% feeling emotionally and physically exhausted, and about 64% feeling ineffective and or detached. The challenge of effective prognostication is linked to clinicians' feelings of ineffectiveness, with many expressing a lack of competency on how to discuss prognoses that are often both emotionally and cognitively difficult for their patients. So, why is prognostic communication so challenging? With so much evidence of why patient prognostic understanding is crucial to reduce the suffering of patients and family with advanced cancer, why is this communication not taking place as much as it needs to in cancer care? The quick answer is that the ability to have effective and compassionate prognostic conversations is quite complex, a whole other area of expertise, such as what a palliative care specialist is trained for, or a psychologist or psychiatrist specializing in serious illness care, and which takes a lot of practice with various techniques and experience to develop these communication skills. Consider the challenges for a doctor of not wanting to cause further stress to an already traumatic situation for their patient and adapting to each individual situation, including any family members present. Prognostic information is also inherently uncertain, so a clinician must develop techniques to convey information in a way that provides useful information while still explaining that estimates given are not precise. Lastly, skillful prognostic communication between physicians and patients takes considerable time that is not always available during a clinical visit. So now looking at patient barriers that prevent prognostic awareness. Psychological factors alone, such as denial, depression, and hope, can create unrealistic prognostic views. language and cultural barriers, difficulties understanding medical terminology, and cognitive impairments, including due to emotional stress or fatigue. These are all well documented as some of the barriers preventing prognostic awareness. It's important to remember that cognitive impairments can include emotional stress or fatigue. Spousal caregivers may not be getting enough sleep, for example, and the patient may be relying on them to remember what was said during an appointment with the oncologist. Oncologists using vague or qualitative references to prognoses and avoiding any mention of death is another well-documented factor which prevents prognostic awareness. Psychological disorders. Many patients or family members may already have an existing psychological disorder, but even if they don't, behavioral health issues are highly likely to develop for people with a serious illness and their family. An advanced cancer diagnosis and fear of death is huge, but stigmas in the U.S. regarding mental health in general can make it more difficult for a patient to ask for help. And into long-term survivorship, this reluctance can escalate over time, including for family members. For example, caregivers are documented as experiencing high rates of distress equaling or exceeding that of their patient, with rates of post-traumatic stress disorders twice as high for caregivers of adult transplant recipients than that of their patient. Research continues to show that the health of family cancer caregivers strongly impacts both short and long-term patient outcomes. When the needs of caregivers are not met, caregiver distress has been shown to increase with long-term survivorship and can lead to negative health outcomes long after the patient has died. Greater patient suffering at the end of life, as you would expect, is also positively associated with the caregiver's psychological distress. And in long-term survivorship, consider how witnessing and sharing their patient suffering for many years is quite traumatic, particularly without full prognostic knowledge of what is going on with the body. Financial hardship for cancer patients and family is huge and is often not discussed during prognostic conversations, yet is a tremendous vulnerability. When financial hardship hits when the patient or family is helpless to do anything about it, the patient can't work, the caregiver can't work, this adds considerable stress to an already horrific situation. Having prognostic information, a physician's diagnosis of what is happening with the body will most likely be necessary for an advanced cancer patient or survivor to get the financial help or other tangible support they need. Experts studying cancer burden and what is called financial toxicity continually emphasize financial stress as being one of the most important factors for patient and family quality of life, and that this should be included in prognostic conversations. There are many interventions currently in use which help patients and caregivers to better communicate with clinicians to gain the prognostic knowledge they need, and which have shown great success. But the problem is that prognostic communication interventions are not widely implemented in cancer care. Only a small percentage of oncologists receive formal training in prognostication, and of these, few receive follow-up training to retain communication skills. This is a partial list of some prominent and excellent prognostic communication programs. Some of these involve clinicians attending a workshop to learn how to use a communication model, and some are solely a guide of protocols which clinicians can follow, such as the Serious Illness Conversation Guide developed by palliative care experts at Dana-Farber Institute, which is part of their serious illness care program. The 4 Habits model, first published in 1995, was developed from a day-long workshop for clinicians, which began in 1990 and has evolved into an excellent consultant program. This communication consultant program is very intensive but highly effective. For instance, consultant intervention can range from one-on-one coaching for oncologists, where audio tapes of office visits with their patients are listened to and feedback is given, such as problem-solving difficult encounters with patients or helping the oncologist practice potential conversations with patients. The AEGIS stands for Ask, Explore, Give, Invite, and Summarize, is another well-tested technique that was adapted from effective cancer communication training programs such as Vital Talk and Spikes. The AEGIS is a 5-step approach similar to Vital Talk's and is a highly useful guide which helps clinicians check for a patient's background knowledge, then guide the patient through choosing their care preferences. Using nurse facilitators such as experienced ICU nurses or oncology nurses as prognostic mediators. This is an intervention I particularly like because it allows for using already existing staff, which of course lowers cost and is then easier for more cancer institutions to implement versus the feasibility issues of working with personnel that are outside the organization. Palliative care is considered the gold standard to support anyone diagnosed with advanced cancer and has been for decades. Although unfortunately palliative is often mistakenly thought to be synonymous with end-of-life care, even by oncologists. So due to this stigma, some cancer care organizations have renamed palliative care services to supportive care, which has resulted in a significant increase of referrals. Early referral to palliative care is shown to drastically improve quality of life for patients and family. And the American Society of Clinical Oncology continues to push for early referral to palliative care following an advanced cancer diagnosis. Unfortunately, there are simply not enough palliative care specialists to fill the need if all cancer care providers were to use palliative care services. So many large cancer centers are continuing to develop long-term supportive care programs in an effort to meet the tremendous needs of our rapidly growing population of advanced cancer survivors. Although sometimes used interchangeably, supportive care is not a synonym for palliative care. Supportive care is a part of cancer care, and palliative care is a field of its own. One example is the adult long-term follow-up program at Memorial Sloan Kettering Cancer Center. This program provides care for survivors who are considered higher risk and with other significant health issues. As the population of long-term survivors continues to grow, however, it's clear that specialized survivor clinics, such as for childhood cancer survivors, and resource-intensive interventions that are necessary to have good prognostic conversations, such as mammogram screening or echocardiograms, usually to monitor for heart issues expected because of the effects of treatment. So it's estimated that these resource-intensive interventions will not be able to care for all survivors as our survivor population continues to grow. Another issue is that survivorship programs are typically centered in metropolitan areas, making the development of programs to reach all survivors, whether they're in a city or a rural area, an additional challenge. So here's a prognostic communication model I'm rather excited about. This is very cost-effective and streamlined. It's still in the trial phase, but has shown good promise. Study results at this point are from trials with patients who were clearly at the end of life, whose cancer was continuing to spread and were highly unlikely to survive more than 12 months. The oncologist intervention, the GIST part, that acronym stands for Giving Information Simply and Transparently. This intervention trains oncologists how to communicate key phrases for patient prognostic understanding. The oncologist technique was demonstrated to be easily mastered by oncologists in less than 2 hours of training and significantly improved patient prognostic understanding. This intervention was also tested as not causing any significant harm to patients' psychological well-being or their therapeutic relationship with their oncologist. So the technique is, rather than focusing on numerical or medical details, the oncologist method uses simple words and phrases that have been shown to make it more likely that a patient gets the basic medical facts that are necessary to see the healthcare choices that they have. For example, the oncologist could say, scans show the cancer is growing, which means that treatment is not stopping the cancer. This means that your cancer is becoming worse and is now more serious. Another example, and one that shows how to use compassionate language, which is possible even with such blunt statements, as well as wording that implies not having exact numbers in prognostic estimates. So an oncologist might say, I wish it were not the case, but for people with your prognosis, the average life expectancy is months, not years. This means that for almost all patients in your situation, I expect survival to now be months, but not years. The final step of the oncologist technique is to ask the patient what they heard. Check for their understanding to make sure they did get the most important facts, and then fill in any gaps in their understanding. If we strip away all the cumbersomeness of methods we would like to use for optimal prognostic communication, we are left with a simple solution. Put prognostic information into every advanced cancer patient's hand in written format. I've developed a conceptual model of how this prognostic tool would work, but will not go into the details here. The most prominent strengths of using hard copy prognostic materials are primarily prognostic discussions with doctors can be well supported by printed prognostic materials and are desired by some patients to help remember verbally delivered information. There's no reason this hard copy material cannot be written in compassionate language that conveys explicit information, yet still helps to maintain hope. There are many foreseeable ethical benefits to printed prognostic materials as an adjunct to clinical discussions, and which also have great potential to increase prognostic understanding. One tremendous benefit is that patients, caregivers, and family members can then absorb, accept, and implement prognostic information at their own pace, whatever is comfortable for them. Printed materials can also be printed in the primary language of patients and caregivers, with assistance available for those with low literacy. This would overcome a huge hurdle to equal access to quality cancer care and prognostic information. Lastly, printed prognostic information is a potentially easily implemented method for any cancer care institution, including under-resourced clinics. As cancer survivorship increases throughout the world, simple printed prognostic information will likely be the only method of delivery which ensures that every advanced cancer patient receives and better understands the knowledge they need for more optimal decision making, and to know what to look for in long-term survivorship, so patients and families can be their own advocates if they're leaving oncological care and are with doctors who may not understand the long-term effects of cancer and cancer treatments. For instance, congestive heart failure is common and ideally needs to have ongoing treatment and monitoring. I want to restate that printed materials should be viewed as a valuable adjunct to verbal communication of prognoses. The oncologist should be directly discussing prognoses, including treatment options and management of symptoms with patients and caregivers. The majority of patients with advanced cancer want their oncologist to competently guide their medical decision making. Oncologists who are knowledgeable about existing trials, willing to discuss alternative treatments, and who empower patients and caregivers with shared decision making are consistently rated as having a higher therapeutic relationship with patients. Thank you so much for joining me. My references for all I have discussed here will be presented in the following slides for those interested. An email address will also be provided if you would like my speaker notes, for example, showing the reference for particular statements I've made. I hope the information presented here will be of help to you and your loved ones to be more proactive in seeking prognostic information. And don't shy away from it. Although it can be hard to hear the truth, it is so much worse not to know what is going on. And I encourage you to be proactive about getting prognostic knowledge, not just for cancer, but for any debilitating disease or health concern, which includes mental and emotional well-being. We know now from neuroscience that there is no separation between our feelings and our bodies. The brain is an organ and responsible for everything we experience. And please remember in our continual drive to find a cure for cancer that we as a society must also support the survivors of cancer who are all contributing heroically to the eventual end of this deadly disease. Everyone deserves access to high-quality cancer care. Everyone deserves to understand the prognostic information available to them, and every person deserves to be treated with respect and dignity. I wish you all well. Thanks again. Take care.